Good afternoon, everyone. I am Dr. Jay Manik. My surname is longest in Scotland. It's Manik Vasagam. I'm one of the ENT consultants from Nine Wells Hospital. I work at Tayside Complete Health as well. Thank you very much for Jillian. She's organizing this talk to all the Tayside GPs through Tayside Complete Health. I'm going to briefly talk about neck lumps and reflux, if possible. I will try and share my screen so that everyone can see. That's great. I hope you can see my screen. And let's make this talk as interactive as much as possible. Neck lump is or the complex stuff to deal, especially at the primary practice, because the GPs are unfortunately having only very minimal amount of time to see the patients, and also the resources what they got is very limited compared to the secondary care, where we have access to all the special gadgets as well as examination skills. I tried to simplify this talk so that they can understand better, and that will increase their confidence. When I asked the survey, what do you really want to learn? The questions, they were raising whom to refer and how to rule out malignancies, and also how to manage them effectively, particularly related to the investigations. Neck lumps are always confusing. Sometimes you feel like you're stuck, and so that's why I'm going to give this talk mainly to focus on few neck lumps which commonly dealt in ENT. Thyroglossal cyst, neck nodes, salivary gland lumps, thyroid lumps, and vascular lumps, if possible, and reflux. If everyone wants to participate in the survey, you can use this menti.com with a ticket code, and you can write your concerns about your neck lumps and also common neck lumps you see in your GP practice. I'm getting the results, and the common neck lumps I think you have mentioned: sebaceous cyst, parotid lumps, thyroid lumps, malignancy. That's very good. And the concerns you raised: missing malignancy, diagnosis, misdiagnosis, delay. Okay, right. So the neck lumps, how to describe the neck lumps, that's very important, because you are going to communicate this to the secondary care. So it's better to describe this lump in a special manner. So you can broadly classify the neck lumps by anatomy, which means there are lumps in the midline, which is very close to thyroid cartilage in the middle, or hyoid bone, or cricoid cartilage, or below the trachea, or in the region of the trachea. Then the anterior triangle and the posterior triangle. It's very easy. It's divided by the sternocleidomastoid, which runs across the neck. So that's divides into anterior and posterior. If you look at this picture there, and you can see the yellow triangle, which is posterior triangle, you can see the sternocleidomastoid muscle starting from the sternum to the mastoid. It's another way of describing the lumps as well. The lumps related to close to the mastoid, or the lumps related to the lower upper part of the sternum. So this triangle is a posterior triangle. And this blue triangle, which sits in front of the sternocleidomastoid, that is anterior triangle, which includes a lump in the thyroid, a lump in the carotid region, and lump in the submandibular region. It all comes in the anterior triangle. Okay. So think about the deep structures of the neck. You have a carotid, you have the thyroid here, just below the thyroid cartilage, just above the trachea, and also the vessels close to the carotids are internal jugular vein. The internal jugular vein is the important vein in the neck because the jugular nodes are situated along the internal jugular vein. So easily you can classify or quote upper jugular vein, which is located in the upper 1/3 of the lump, 1/3 of the jugular vein, and the mid-third that is called the mid-jugular vein nodes, and the lower ones are lower jugular nodes. This is another way of classifying the lymph nodes. The patients are smart nowadays. He's trying to impress his in-laws. The point I'm trying to make here is patients read a lot in the internet and they come with enough knowledge, which is sometimes dangerous, but end of the day, it's not going to make the consultation very pleasant. At the same time, they expect more from the doctors as well. Neck lumps, midline neck swellings. The thyroid is one of the commonest lump, which is normally dealt by ENT or general surgery. Increasingly in UK, it's dealt by ENT because thyroid lumps are associated with the swallowing and airway problems. It's dealt by ENT. And the Thyroglossal Cyst, which is similar to the thyroid lump, which is slightly located higher. And dermoid cyst is very similar to the Thyroglossal Cyst because the dermoid cyst appear in the midlines or wherever the fusion happens. It's a congenital type of lumps. So when you see any midline lumps, the questions you need to ask, does it move with the swallowing? That's good. In that case, it could be either thyroid or Thyroglossal cyst. Does it move with the sticking out? So that, especially with the tongue, it means that's the Thyroglossal cyst. The reason behind it, the Thyroglossal cyst originally arising from the back of the tongue, it descends down. So it's still attached with some kind of track, which actually passes through the hyoid bone. So that's why it moves with the protrusion of the tongue as well. So this is a thyroid lump, which you can see. It is in the midline, but as you know, the thyroid has right and left lobes and attached to the isthmus, so you can have a lump on the right-hand side or left-hand side or in the middle. The question is, does it move with the deglutition? That's the important thing, okay? And take the relevant history in the thyroid. The thyroid lumps are the most important things you need to ask in thyroid lump is onset, duration, the progression of the symptoms, and associated symptoms. For example, thyroid lumps can present with swallowing problems because it's a compression with a large lump. And the next thing you need to ask is hoarseness, because thyroid cancer can compress or infiltrate the recurrent laryngeal nerve, and that can cause vocal cord palsy. That is a sign of malignancy. Some of the thyroid cancer can cause airway problems. So the thyroid lumps are generally considered as not urgent, but when you see fast-growing thyroid lump with dysphagia or hoarseness, that needs to be referred to urgent manner. But rest of the lumps, it can be can be a routine referral, because thyroid cancers majority of them are well differentiated and they have a very good, excellent prognosis. So it's not necessary you need to refer them within 2-3 weeks on an urgent basis. You can see this picture is a thyroglossal cyst, which is a cystic lump. Sometimes it's like a plain cyst, or sometimes it's got infected. It causes a huge swelling, and it can present like a discharge, which is a recurrent discharge. Sometimes you may need antibiotic. More the infections you got, more often the increase the frequency of infection, which makes the surgery difficult, because this surgery involves removing the whole tract. The tract has got sometimes branches. If you don't remove it fully, there is more chance of recurrence, and the recurrent thyroglossal cysts are extremely challenging to remove. It usually affects in the teenage, or sometimes is a little later, around second or third decades. This is a large thyroglossal cyst which has been removed, part of the high bone and the tumor, the tract up to the tongue base. It's not necessary thyroglossal cyst needs to be larger or typical cyst, and this patient has got a recurrent discharge in the midline for a few years. It comes and goes. This is typical of infected thyroglossal cyst present with the discharge. So coming to the thyroid lump, it is nowadays we are picking up more thyroid lumps because we are doing more ultrasound scan. Fortunately, 95% of the nodules are benign, and if you do ultrasound scan, you can detect nodules up to 60% of the people. What examination you do? Palpate the thyroid lump, find out which lobes are involved. Is it uniformly enlarged? You can feel nodules. And also check where there is any extra nodules next to the thyroid gland. That means the thyroid gland with neck nodes, which is not a good sign as well. And that might be a sign of malignancy as well. And also it's worth checking whether the thyroid lump is extending down below, for example, the retrosternum, and also look for signs of hyper or hypothyroidism, which is not very relevant completely with the surgeons, but it is always recommended the GPs do some thyroid function test to make sure the patient is in euthyroid. So apart from doing the thyroid function test, what are the other investigations you do? That is ultrasound scan. It is a balance whether you do ultrasound scan for every patient or on and off, and that's a question. But regarding the thyroid lump is concerned, the first and foremost investigation is ultrasound scan. I'll tell you why. Because as I said earlier, apart from taking the history and look out for pressure symptoms, dysphagia, dyspnea, hoarseness, and weight loss, and the risk factors and red flag signs. Risk factors, for example, age beyond 55 is a high risk, and our children with the thyroid lumps are tricky, and family history of thyroid cancer, any previous radiation, and thyroiditis, because the thyroiditis can cause Hashimoto's thyroiditis can relate to the lymphoma, radiation, previous radiation in that field related to the papillary thyroid cancer. Okay. And family history is related to the medullary thyroid cancer. Examinations at the secondary care, we do flexible nasal endoscopy to rule out vocal cord palsy, but for your primary care, you focus on hoarseness as well, and also the lymph nodes and breathlessness. Those are the three things you need urgent referral. Investigations, Ultrasound Guided Fna is a gold standard. The reason behind this, the ultrasound with the new criteria from thyroid guidelines, and they categorize into U1 to U5, very similar to the breast malignancies. U1 and U2 is benign, which means you don't need to do any more investigation. Even you don't have to do FNA. That's what the guideline shows. They could be discharged or monitored because there's not much increased evidence for developing malignancy. Unless the patient presents with a large lump which has got some pressure symptoms, the patient doesn't want that lump, that can be removed. And U3 is equivocal. It means there is a good chance it could be malignant. So those cases needs further investigations in the form of fine needle aspiration cytology. And U4 and U5, we are nearing to the malignancy border. U5 is definite malignancy, U4 is suspicious malignancy. In general, from U3, U4, U5, the patients will end up having fine needle aspiration cytology, likely followed by diagnostic hemithyroidectomy. So that's the new coding for ultrasound scan we are trying to implement for increasing the uniform reporting system. So after the fine needle aspiration cytology, we review them again. That's again classified as a Thy 1 to 5. It is very similar. 1 is inadequate. In that case, we have to repeat the ultrasound scan again in 3 to 6 months' time. We don't want to repeat so often because repeating too often can cause artifact. It's difficult to interpret psychologically. Thy 2 is a benign, which is a good news. In that case, it doesn't need any more, or it may need one more cytology sample to confirm again benign, then it can be discharged. Thy 3 is suspicious. 4 and 4 is Thy 3 is intermittent. Thy 3 is a follicular. Thy 4 is suspicious. Thy 5 is malignant. So eventually, Thy 3, 4, 5 most likely end up thyroid surgery to confirm. In Thy 3 cases, there is a 50% chance of malignant. Thy 4 is nearly 85% chance of malignant. Thy 5 is almost 95 to 98% malignant. When you look at the thyroid lump clinical examination, it can be a large lump on one side. This is like a kind of multinodular goiter involving all the lobes and the thyroid, including the retrosternal extension. And this one is a large thyroid lump on one side, and the other nodules, and as well as the neck nodes on the next side. That shows it's kind of malignancy. And sometimes you won't even feel the lump, only the ultrasound picks up the large thyroid lump because of the nature of the neck. So how you interpret things, that's important things. For example, in UK, the thyroid cancers or thyroid lumps are managed more conservative manner. We don't do much thyroid surgery. But if you look at the Germany or other countries like USA, more thyroid surgeries are done. That's is something to do with their system and maybe private practice. But it clearly shows the evidence conservative approach doesn't affect the survival. In fact, it's a preferred approach. And in some other countries like Japan, they are even more conservative with the thyroid malignancies. This is the large thyroid lump, airway lumps, which is commonly managed in ENT, because you can see it's nearly more than 2 kilos of thyroids. Has been living with this patient, living with that for a few years. And that started causing exertional dyspnea. This is not a cancer, but she kind of very much restricted in her activities. If you look at that endoscopic picture, that larynx and trachea is collapses, the patient is developing tracheomalacia. So these sort of patients get a lot of benefit after removing the thyroid lump, and these patients kept a few days in the intensive care unit, and they recover very well. And the tracheomalacia is not a huge problem while doing the operation. You can see the CT scan started squeezing the trachea. It's like a kind of teardrop shaped instead of normal round or D-shaped. So just to summarize for the thyroid, take a relevant history and examine the thyroid lump, and ultrasound if we have an option of organizing those things, and always request for FNAC in the thyroid lumps, which is very important if you have option. CT scan, we don't routinely do it. We do it only if we suspect airway problems, swallowing problems, or metastatic neck nodes. And we don't do a radioiodine scan as a routine, as a preliminary investigations. It is mainly done after diagnosing the cancer, if we suspect post-op radioiodine treatment for thyroid cancers. Next one is other swellings, for example, lymph nodes, branchial cysts, salivary gland, and carotid body tumors. The posterior triangle, you commonly get lymph nodes or cystic hygroma, examine these neck lumps in a good light, neck slightly extended, not overextended and not overflexed. As you know, neck nodes are commonest neck lumps, it's caused by infection or malignancy, hematological conditions, for example, a lymphoma commonly, or leukemia can present with multiple neck nodes. So again, get the relevant history. The question is it comes and goes? Is it progressive? What was the original size? And how long it's been there? And what are the other systemic symptoms, for example, fever, weight loss, sweats? It can be a lymphoma or kind of tuberculosis type of things, or some other kind of things like sarcoidosis, ID type of things. Specific symptoms are related to the lump. The specific symptoms to ENT, for example, this tumor in the hypopharynx that can cause swallowing problems, and the tumor extending to the vocal cords and airway causes cough and hoarseness and dyspnea. And if you think strongly, some infections, some infected lymph nodes, recent travel or to Australia or the New Zealand, or travel from some other countries, Asian countries. Sometimes the anatomical location give you the cause of nodes. For example, level 2 nodes are related to tonsil and tongue base, and level 5 nodes are related to the nasopharynx tumor, and maybe the one below the level 4 and 5, which I have not shown earlier, that might relate to the thyroid lump. The levels of the neck is another way of describing. The level 1 is submental. Level 2 is submandibular, and level 3 level 2 is upper jugular, level 3 is mid jugular, level 4 is lower jugular, level 5 is the posterior one, group of nodes, and level 6 is in the pretracheal near the thyroid area, mid-center portion, and level 7 is the mediastinal nodes. That's the technical or radiological location as well. So when you see the neck nodes, look out for the watch out the position and the size, which is the most important things. Generally, the neck, if you have a 1 centimeter, less than 1 centimeter node, we think that is still okay most of the time on clinical examination. But at the level 2, which is a tonsillar node, which is it can up to 1.5 centimeter. But the shape, usually it's a oval in shape. If it is round and hard and consistency, that's not good news. And Generally, lymphomas are like more rubbery and multiple, and also they can have a lymph nodes in the armpit, in the groin, or in the abdomen. So examination of the primary sites, especially the tonsil region, and if possible, nasopharynx related one as well, like a nosebleed or nasal blockage, and that or referred pain in the ear. These are all hypopharyngeal or tonsillar malignancies is important. And associated lymph nodes in the armpit, groin, and the abdomen, it might be useful sometimes. So the primary site is sometimes useful because, for example, they have a SCC removed by the plastic surgeon in the chin or in the scalp a few years back, and then they develop lymph nodes in the parotid. Actually, that is not a parotid gland swelling. It is lymph nodes in the parotid, and the preauricular region got swollen, and that is typical of SCC metastasis from the skin. And look for, as I said earlier, the primary sites. So for investigations for the lymph nodes, chest X-ray, it's helpful because lung malignancies, particularly present with the left supraclavicular nodes, which is left level 5. Because, as you know, that's the thoracic duct starts from the abdomen, comes through the chest, and opens into the joins, the jugular vein there. That's where they get lymph nodes there. And if you have option of needle aspiration, that's fine. But I guess GPs don't do those things, and the ENT opinion is crucial. So this is a simple, simplistic flow diagram which shows cervical lymph nodes only in the neck, and look for primary, and ENT chest X-ray, possible biopsy. If it is generalized, look out for a liver, spleen, hematology, but still hematology asks for ENT opinion. For tissue diagnosis, we do either co-biopsy or lymph node biopsy for the diagnosis. Simultaneously, some GPs refer to both specialties, which is also fine. Solitary nodules sometimes needs biopsy as well. So when you look at this one, you can see this is a painful lump for 7 days, which is kind of red, which is in the region of submandibular region. It's a tender. It's kind of drained twice. Typically, this is submandibular neck lump, which is the cause is infection. This is caused by the infected tooth. That was the source of infection. Next is a branchial cyst. What is branchial cyst? It's all congenital cyst because when the neck is developed, it forms like a buds. When the buds join, then there are inclusions. That's where the cyst happens. It is usually comes in teenagers, but when you look at these things, it's a smooth cyst on the MRI scan, medium, large size tonsils. You have taken that cyst, and there's an internal jugular vein underneath. Sometimes it's associated with the some other cyst and tracts as well. Keep that in mind. The reason I'm talking about the branchial cyst before the oropharyngeal cancer, nowadays we do see HPV cancers, which usually present with similar cystic metastasis in the neck, and they are all non-smokers, young, and sometimes it get confused with the branchial cyst. So now the system is tuned for it could be a cystic metastasis from the HPV cancer until proven otherwise. So even though we think it could be branchial cyst, but it could be very well be a cystic metastasis. If you look at this oropharyngeal cancers, you can see there is an ulcer in the tonsil. This is a smooth mass in the tonsil, and this is like kind of verrucous type of lesion. All the three of them are HPV positive cancer in the oral cavity, oral pharynx, that presents with neck nodes. These patients are needing kind of urgent referral. If you look at the same patient on the different photographic views, it's a large 6 centimeter cystic nodes. Even the MRI confirms it is not a branchial cyst. He's a 46-year-old man. This is typical of HPV cancer. Sometimes you may not be able to find the primary cancer that we call that as an unknown primary. If you can't find a primary, doesn't mean they don't have a primary. These primaries are tiny, situated usually in the tonsil and tongue base, and to some extent nasopharynx. Now we got a knowledge. These are all again caused by, most of them are caused by HPV tumors, but they present with a large neck nodes. So if you look at this patient, you can vote in the Menti. Do you think this patient needing urgent referral to the ENT? People are voting. That's good news. I'm glad. I think everyone said, yes, this patient needs referral to urgent ENT because it's a persistent lump, which is getting bigger in size. It is exactly situated in the upper jugular, which is a level 2 or /3. Nodes is typical draining site of a tonsil, primary, tongue base, or hypopharynx tumor. And this is 50-year-old man. So when you come to the secondary care and then this hair MRI scan, you can clearly see actually, and there's a tonsil tumor which you can't see because it's a small tumor with the neck nodes with abnormal character. It was referred as unknown primary. But after the scan, we found the primary it's become tonsil cancer. So this is increasingly we see because of the HPV tumor and the smoking-related cancers are going down. And in TSI, almost 70% of the tonsil tongue-based cancers are HPV tumor at this point of time. Take a full history, and interestingly, the history, you may not get any positive findings. They are not like smokers. They're not like old age patients, and they don't feel ill, and that's an important thing. And they look absolutely normal. In fact, they have they come from higher socioeconomic status. And but important thing is good examination of the mouth. In fact, sometimes quite feeling the tonsil might give you an idea rather than looking at that one. And feeling the tongue base is a good option with the gloves as well. So and also look at the lump and ask for alcohol and smoking history. Most of them, they may not have anything. So don't get biased about these findings. Sometimes this is a large lump. He had a cancer 5 years ago, treated by HPV cancer, treated by chemoradiotherapy. Again, they can present with lumps. So think about recurrence, which is also increasingly we see because the initial tumors are treated by chemoradiotherapy, and these tumors they appear when they are young. And 10 years later or 15 years later, they could develop a second tumor as well. And this patient had extensive surgery. We treat the multimodality treatment, and that improves their survival as well. So salivary glands, the next one is either it could be arising from the submandibular gland or the parotid gland. The mandibular gland commonly develops stones. That's because this is located under the tongue. The duct drains against the gravity. So, and also the nature of the gland produces more thick secretions that predispose to stone. But they do develop nodes as well as benign as well as malignant tumors that needs to be investigated similar way either by fine needle aspiration cytology, ultrasound, or even MRI scan. Parotid gland can develop parotitis or infective silodinitis, which is very common. That's due to a dehydration, poor oral hygiene. If that comes and goes, maybe one time, then you can advise some gentle massaging and more hydration, good mouth hygiene. That goes away. For some patients, might need further investigation because of the recurrent problems, and it extends from a xylogram or even going treat them aggressively by endoscopic approaches, or sometimes excision. Pleomorphic adenoma is a benign tumor, which is the commonest lump we treat, and we do advise surgery because it has a tendency to grow bigger, and also it can become malignant over a period of time. And also sometimes it's salivary gland tumors are hard to diagnose with a needle biopsy. So they may need a definitive excision to prove or rule out malignancy. And also it's easier to remove when it is small. Parotid can develop stones as well, but it's very rare. This is a simple the post-op pictures. You can see I do parotidectomy as a day case procedure. So it says I'm the only one does that. We've done nearly more than 50 patients and with the highest patient satisfaction. I don't use any drains. This is a facial nerve. You can see that's why it's very delicate. I use a nerve monitoring service to minimize the facial nerve injury. Our complications rates are much lower than the national average. So this is a lady in 60s, noticed a lump in the left submandibular region. The reason I put the good mouth opening, this is another one to test it, because if it is a strong infection, they do develop trismus, and because of the involvement of the deeper muscles. This is initially treated with antibiotics by GP, but not responding well. We admitted the patient, then we done the CT scan and bloods, and we also given antibiotics through IV. But if you look at the scan, there's this kind of uniform lump there. There are also multiple lymph nodes along that one, and on further co-biopsy, which showed, and that turned out to be CLL, chronic lymphocytic leukemia. They present with neck nodes as well. And this one is a lump in the submandibular region, but I don't know how many of you see the dimple called punctum, and that it's a simple sebaceous cyst as well. This is a typical parotid lump sitting in front of the ear in the region of the parotid. 82-year-old gentleman for 2 months, and GP managed to the ultrasound scan. That came back as a pleomorphic adenoma. But sometimes we see them as a routine, these patients, because it's a nature, it's a benign lump. But the important thing is the parotid lump. When do you suspect malignancy? Infiltration of the facial nerve, facial weakness, that's malignancy. Skin infiltration, the skin is not able to pinch, and that's malignancy. And the rapidly growing lump is a malignancy. And the associated pain, that is not good sign. And also this lump, there is another lump comes up, that these are all abnormal findings. We need to manage them urgently as well. So to some extent in Tayside, I treat all the parotid lumps on urgent basis because of many reasons. And this patient, further, we managed to see them a bit later than expected, but the MRI scan showed irregular margins. Then it's turned out to be malignancy, and this because it was infiltrating the skin, patient needed a big surgery of 8 hours, removing the lump and sacrificing the facial nerve, and we had to remove the skin as well. So we patched it. We did a local flap and lift the skin. Eventually, we closed it like this. So sometimes this is one of the rare lumps. We are coming to the final part of the discussion. So vascular lumps, and this is typically located between the branches of the carotid. So that itself give you a clue. This is a carotid body tumor. And these tumors are long-standing. So usually this lady, 42-year-old, had a 3 years history of lump in that region, and extensive investigations, because these patients can present with multiple uh, paragangliomas. For example, they could develop adrenal tumors or spinal paragangliomas. Usually I discuss this in the endocrine MDT. I set up the thyroid endocrine team with a vascular surgeon as well, and this patient was removed. Interestingly, her sister had a pheochromocytoma, and it was removed in a different hospital. And her mom had other paragangliomas in the spinal region. So it runs in families. So if you look at the history, if you take anybody in the family has similar, then it can tie up easily. For example, genetic and familial, it can be a functional. They may have developed like adrenal pheochromocytomas with derange the blood pressures and heart rates. It can be on other side as well. I have seen one patient last year referred to me for one side. Then I did a scan. I found actually there is a tumor on the other side, lump on the other side as well. Or they can have a multiple lumps. The same patient, one of my patients had a spinal gangliomas, which was removed a year later, and then I removed the carotid body tumor. We do the setup for them for genetic counseling, endocrine opinions, sometimes functional scans. These are all the different modalities of the treatment, because it's a very, very challenging operation to do, because you operate on the carotid. Last but not least, there are some lumps in the supraclavicular region. This is a tricky area, to be honest, because that's why I said this is where the thoracic duct drains from the chest and abdomen. Most of the bad lumps from the lungs or mediastinum, or in females, it's from ovary or abdomen, and they can have lymph nodes as well. But this one is very soft. It's been there for a while, so you can clearly see this is lymphoma. Is a benign lump. Sometimes we don't remove that one, but this patient felt it is about 5 to 8 centimeters, getting bigger. That's why we removed. For the small lumps, we don't have to remove it. So we discuss about the triangles and management of lymph nodes, thyroid lumps, thyroglossal cyst, and the salivary glands and the nodules. Okay. So lastly, I want to touch base with reflex treatment. It's always a debate. I want to just mention the two: systematic review and meta-analysis, a proton pump inhibitor therapy for the treatment of the laryngopharyngeal reflex, and also meta-analysis for the proton pump treatment, laryngopharyngeal reflex. So this clearly shows alginate therapy is effective treatment of GERD symptoms. That's Gaviscon and or maybe peptide type of groups are better. And this one is compared to PPIs or H2 receptor antagonists like kind of ranitidine, appears less effective, but pooled estimate was not statistically significant. So what they're recommending are PPIs are better, and also alginates are more effective than placebo or antacids for treating GERD symptoms. But how long do you give? But again, that is, in my opinion, I won't give them for a long-term basis. I manage them with alginates and lifestyle modification. That's the most important things. And we have nice information leaflets, weight reduction, dietary changes, and lifestyle changes, and that is more than enough. But you can give a short course of PPIs, like up to 2 to 3 months. Then you can always restart if symptoms are not getting better. But if you put them on PPI for long term, like 10 years, 20 years, or from you start them on 40, then they'll live for 80 years nowadays. 40 years of PPI is not really good as well. Okay, I think that's end of my talk. I'm happy to take any questions. Please feel free to kind of email me, or if you need any questions, or if you need any other talks, I'm happy to give you the talk. Thank you. That's good. I think that's my talk about these things. Thank you. Thanks for listening.